everybody, and welcome back. This is Peter Pronovost, and today we're going to discuss the Comprehensive Unit-Based Safety Program, or what we commonly call CUSP. It's an intervention that will help you learn from mistakes and improve safety culture. The Harvard Business Review had a great article in which they interviewed the CEO of Toyota and asked him what the magic of their success was. And he eloquently said, rather simply, we learn from mistakes continuously and we create a culture of teamwork. And in essence, that's what CUSP is intended to do within your healthcare organizations. And we've had dramatic success in doing so in Johns Hopkins and in intensive care units throughout Michigan. The learning objectives for today are to help you understand the steps in CUSP, to learn how to investigate a defect, one of the steps of CUSP, and to understand some of the teamwork tools such as daily goals, AM briefing, and shadowing. Now, we will have separate modules on investigating mistakes, on daily goals, and on AM briefing. So again, don't worry that you need to get everything in this one session. I want to frame for you, though, the bigger picture of where CUSP fits in. When we think about our safety scorecard that we use within healthcare organizations, it has 4 types of measures. How often do we harm, or outcome measures? How often do we do what we should? That is, process measures of the use of evidence-based medicine. How often do we learn from mistakes? A measure that's not a rate, but simply all those things that go bump in the night. How do we know we're reducing risks? And lastly, have we created a culture of safety? Now, CUSP is the intervention that seeks to improve the latter 2. That is, it seeks to improve how often do we learn from our mistakes and have we created a safe culture. Now, before you start CUSP, there's some key components that you need to do. The first is you have to create an ICU team. You've been working on that already with the teams that you've put together. But these teams ought to be composed of a nurse, a physician, an administrator, perhaps others, and you need to assign a team leader who's going to organize and coordinate this work. The teams seem to work most effectively if they meet weekly and have a clear agenda of what they're trying to accomplish. You also should measure culture in the ICU. And I know many of your organizations have begun to measure culture across your whole hospital, and that's fine. We'll just use your ICU's results. But the point is, before you start this work, we want to know where we stand with regards to how safe your culture is in your ICU. And lastly, you should start to talk with your hospital quality or safety leaders to, 1, make sure they know about this project, and 2, have them assign a senior executive to be part of your ICU team. And we'll talk about that a bit in the next steps. CUSP is in many sense nothing more than a shell for how you could both learn from mistakes and improve culture. It's designed to be implemented at the unit level, but hopefully you'll aggregate units so that you have many CUSP teams throughout your whole organization. At Johns Hopkins, we select the units that have the lowest culture score to implement CUSP, and we add units every year. The steps of CUSP are, 1, to educate staff on the science of safety. You are now all safety scholars and you understand those basic principles, but most of your staff won't have the benefit of that training. And so we hope that they'll watch these slides and really understand this science that underlies safety. Step 2 is to identify defects. Step 3 is to assign an executive to adopt your unit. This is different than walk rounds. This is the executive becomes part of the team, meets with the teams monthly, holds them accountable for their learnings, and makes sure they have the resources to do the work they need to do. We're then going to ask you to learn from 1 defect a quarter using a structured tool of learning from mistakes. And then finally, implement some of the teamwork tools that best address your unit's teamwork needs. Now, I hope you all remember, this is a test of how well you learned, what the science of safety is. And fundamentally, it boils down to a couple key steps, or a couple key concepts. First, understand that the system determines performance, so that if we want to improve, we're going to need to improve or change the system. Second, understand that there's some basic strategies to improve system performance. They are: 1, standardize what you do and when you do it. 2, to create independent checks or checklists for things that are mission critical. And 3, have a process to continually learn from mistakes. The next concept of the science of safety is to recognize that these strategies apply not just to technical work, but also to your teamwork. So have standardized ways to communicate with each other. And then finally, recognize that teams make wise decisions with diverse and independent input. So listen to nurses, or nurses speak up when you have concerns, not that because it's a nicety, but because the lives of your patients depend on it. Step 2 of this process is to identify defects. And let's here just agree that a defect is anything, be it clinical or operational, that you don't want to have happen again. Really simple definition. Something happens and you say, oh, shouldn't happen again in our healthcare system. That's a defect. That's what we're talking about here. And there's many sources of defects. There's error reporting systems now that many of you have and are a great source of defects. There's liability claims, there's sentinel events, there's issues that come up in morbidity and mortality, or what's commonly called M&M conferences. But perhaps most powerfully and most simply is simply to ask your staff how the next patient will be harmed. You see, a fundamental tenet of the Toyota system and of CUSP is that your staff who are on the front line caring for patients every day have wisdom and knowledge that we need to tap into. And every time we've asked staff how the next patient's going to be harmed, they provide us enough work for a year. They know what the hazards are. We just, to a large extent, haven't asked. Okay, now you have this huge list of defects. What do you do with it? Well, first, I'd create a list and literally write them down on a piece of paper or an Excel spreadsheet, and then discuss with staff what they think are the 3 greatest risks. Now, we tried doing this with more formal methods of prioritizing, ranking the severity, the frequency, the ability to defend against them, and assigning a priority number. To be honest, that was overly complicated and didn't work very well. Rather, simply listening to the staff and asking them what they felt the greatest hazards were was far more efficient and effective. So now you have a list of your greatest priorities, and it's time to start the executive partnership. The executive should become a member of this ICU team. They should meet monthly with the team. The team will hopefully meet weekly, but the executive can meet monthly. And what should they do? Well, they should do a number of things. We want them to review your defects. We want them to make sure that you have the resources needed to reduce these risks and hazards, and to hold you accountable for making sure that you systematically address and reduce these mistakes every month or every quarter. And finally, once we start working on reducing central line infections, that they hold you accountable for what those rates of those infections are. So every month they say, have we had any infections and what have we done to reduce those? Now, learning from mistakes is a science into itself. And we'll have a whole session on this, and we'll go in great depth in this. But you can call it a root cause analysis. You can call it an FMEA. I'm going to be really simple and say, how do we define learning from mistakes? Well, by learning, I don't mean recovery. That is, something goes wrong. The supply isn't available. The test isn't drawn, and you go get the supply or you go draw the lab test. That's recovery, not learning. Learning means reducing the risk that future patients will be harmed or suffer the same defect. And to do learning, we want you to walk through 4 simple but very practical questions. You could almost think of it as a root cause light. The first is, what happened? What are the facts? Second, why did it happen? And you may need to ask why 5 times or more, just like they do in the Toyota production system or like they do in root cause analysis. Now that you have lenses to see systems, the goal of asking why did it happen is for you to clarify what were those systems that were risky that led to the event. Next, what will you do to reduce the risk of future patients being harmed? That is, what are you actually going to do to make this system improved? And you can use our principles of safe design. I hope you see how this all fits together here. Those principles are, what could you standardize? What checklist or independent checks could you make? And what system do you have for monitoring that when things go wrong, you will learn? And then finally, and perhaps most neglected in healthcare, is how do you know that you actually reduced risks? And the approach here is to say, did I create some policy or process or procedure? That, quite frankly, doesn't give me great comfort, but it's the kind of less intensive but also least valid approach. Second, how do we know staff know about this new policy or procedure? And lastly, have we actually measured that staff are using it correctly? You'll hear later on that we're working on an even more valid way where we're going to ask the frontline clinicians, do they actually perceive risk was reduced? How do you identify these contributing factors? Or you have, why did it happen? Well, one of the ways you can do that is that you can rate each contributing factor on 2 variables. The first is, how important is that factor to the problem in causing this particular accident? And then second, how important is it going to be in future accidents? The goal here is to help you laserly focus on those contributing factors that most contributed to this event and to future events. Because what we've seen over the history of root cause analysis is, as you develop lenses to see systems, you will get very good at picking up contributing factors. Indeed, you may pick up 5 or 10 or 15 contributing factors, but they're all not equally important. And you can't fix all 15. That's a recipe for disaster. So you need to start prioritizing. Likewise, when you go to develop interventions, we want you to focus on those interventions that are most likely to reduce risk. You can't implement 10 or 12 interventions. You don't have resources for that. So you need to prioritize and focus like a laser to say, for each intervention, how well will this intervention solve the problem or mitigate that contributing factor that most likely drives the risk for the accident? And then secondly, you have to rate the team's belief. This is your improvement team, that they believe that the intervention could actually be implemented and executed as intended. I can't tell you how many times we've seen interventions recommended as root cause analysis where the team who's even recommending them knows there's not a prayer that that intervention is going to be implemented as it's planned. They either don't have the resources or the culture just doesn't support it or there's not political buy-in, but it doesn't make any sense to recommend an intervention that you know is going to fail. You want to recommend interventions that will address your key problems and that are likely going to be executed successfully. How do we know whether risk is reduced? Well, think about asking, did I create a policy or procedure? The lowest level of validity, but also the lowest resources. We don't have resources to do everything. We have to make trade-offs about where do we spend our precious resources. 2, do staff actually know about the policy? So some knowledge assessment of this new policy. 3 is, are staff using it as intended? So that's typically some audit, either observing behavior or observing a process, but are you actually doing what you intended to do? And lastly, and perhaps most valid, asking your staff, do they believe that risk has actually been reduced? So after they do something, go ahead and get some knowledge from them to say, hey, has this really worked? And if not, why not? The last step in the CUSP program is for you to implement teamwork tools. And we've developed a number of them, and we'll go through many of them in future sessions. But what we'd like you to do is, as you get your safety culture results from your team, sit down with them and review how you scored on teamwork and have a discussion with them to try to understand what is broken about teamwork in their ICUs and what works really well. And then ask them, what would it look like if we had excellent teamwork? What you're trying to do is to match up what their perceptions of teamwork are with some concrete interventions that could improve them. So, for example, in many ICUs, the nurses say, we just don't know who to even call when something goes wrong. There's not clarity about who is the physician in charge. Well, for that, we would say, why don't you go create a call list? Create a system that you do know that. Whenever we ask, though, how the next patient is going to be harmed, step 2 in the CUSP program, over 80% of staff say it's because that there's poor communication between the doctors and nurses. And one really effective tool for that is the daily goals tool. And we'll go into that in great detail in the future. But essentially, it's a way to make sure every day on rounds, the doctors and nurses round together, they identify what work is going to be needed to get this patient to the next level of care, in this case, out of the intensive care unit. And then they're laserly focused on saying, and what are we going to do today towards that goal? And we ensure that the doctors and nurses all know that work and work together towards that goal. They also ask what this patient's greatest safety risk is and try to mitigate that. Other tools include the AM briefing, where the ICU physician and nurse directors meet in the morning to ask what happened overnight, who's coming and going today, and what are our concerns today. Shadowing, where one caregiver type follows another caregiver type and then asks, what am I going to do differently now that I've walked in your shoes? The shadowing, it's something we borrowed from Southwest Airlines, is a remarkably powerful tool that we strongly encourage you to try and implement. And then finally, a culture checkup. Because we only measure culture yearly, it's a long time to get feedback on how you're doing in culture. So we've built a tool to allow you to do a qualitative rather than a quantitative assessment of culture, where you sit down with your staff and ask them, have we made any progress on our teamwork? And if so, what did we do that led to that? If not, what could we do to make teamwork better? The call list, if you don't have one, I strongly recommend you to create one. It's simply a process to say, how do we know that in your ICU that your staff know who's the physician to page for each patient? As you know, responsibilities for physician changes between day and night, between weekday and weekends, and you need a seamless process to make sure that that happens. Again, every system is perfectly designed to achieve the results that it gets. Do you have a system in your ICU to make sure that the nurses know who to call when they need to get in touch with a physician? That could be paper-based, it could be electronic. The point is, it has to be easily accessible and frequently updated. This often isn't a technology problem. It's a problem with assigning someone responsibility to update it. It's a human problem. The AM briefing I mentioned earlier quite briefly, the idea is that the leadership team of the ICU meets every day in the morning and plans the work for the day. That is, they discuss what happened at night, who's going to be admitted and discharged, and what are the risks that we need to try to mitigate during the day. Shadowing, amazingly powerful tool. What we ask you to do is to follow another clinician type for 2 hours to 4 hours, and then discuss what work are you going to do differently now that you've walked in someone's shoes. I'll share with you, we have our medical students do this as part of our safety course, where they shadow a nurse for 2 to 4 hours and then ask what hazards did they see or what defects did they see, how was communication. And now that they have lenses to see systems, they come up with some profound insights about improving care and improving safety. And I have no doubt you will do the same if you do too. The teamwork tools, though there's a number of them, what you need to do is find out what are the challenges in communication that your team is facing and select the tool that best meets their needs. Perhaps you'll need all of them and you can pick one a month to do it. Now, recognize that this CUSP is a sequential and continuous journey. Each step builds on each other, but ideally you have a system to learn from one mistake every month or every quarter continuously. So you use these tools and you are constantly working on and continuously improving your teamwork and adding new tools for that. Some of the challenges we've seen or where shortcomings have occurred is if a unit doesn't make the science of safety part of orientation. Because you have 15 to 20% turnover, you have to build it into your orientation. You have to make sure that there's a disciplined approach to learn from one defect a month or a quarter and share those lessons with each other. The sharing is simply a piece of paper that answers those 4 questions that you post and learn from other people in your ICU and then outside of your ICU to other units in the hospital, because we've seen we're much more alike than different. Other units are struggling with the exact same issues you are. To make sure you do teamwork tools that best meet your needs. And we've provided you with a manual of operations that have all the details of these CUSP tools that you possibly could need. Since many of you don't read it, it's too much overkill, and the slides and these audio files are enough. But know that the resources are there. So if you want tools to say, how do I ask about how the next patient will be harmed? Each of these steps are outlined and provided for you in excruciating detail. We've provided you with references to guide this work if you want the original publications. But most importantly, we want you to make sure that you have a process to continually work to learn from mistakes and improve your safety culture, because patients need to be our North Star, and we cannot afford to have another Josie King at your hospital or mine. So when her mother comes to you and says to you, how do you know Josie is less likely to die? You could answer her with a resounding yes, because these are the things that you've done to make teamwork better and to learn from your mistakes. Godspeed and working with you to improve patient safety. This is Peter Pronovost.